Thank you, my lady. Good afternoon, Professor Hopkins. I ask questions on behalf of the COVID Bereaved Families for Justice UK. I'm going to ask you questions on 3 topics. I'm grateful to Ms Carey for covering in some detail one of my topics I was going to address with you. That was around domiciliary care. I'm going to focus my questions, first of all, back on the March 2020 hospital discharge policy. You've used the word in your evidence today that you were surprised on the 17th of March 2020 by the DHSC policy. Should, in your view, Public Health England have been cited on that policy at the ground level rather than being surprised?
So it was in NHS England, not DHSC, just to... so clearly, as organisations who send out information, we don't see all of the information that goes out on a routine basis today or any day that goes out to organisations. However, what we learnt in the pandemic and what we learned really in events like this was that we needed a single clearing system, which is what we developed. It was a single clearing system for all guidance going out that was clear on who saw what when and how it went. But that was not in place in March.
So the learning was, yes, we need to be cited. Does it follow then that you should have ideally been cited on this when it happened?
So we should have been. I don't think it would have necessarily changed what we could have done at that time, but I think we should have been cited.
Thank you. In her statement for Module 3, Amanda Pritchard, the then Chief Operating Officer, the NHS, said that on the 17th of March, discussions took place at the NHS National Incident Response Board meeting about the hospital discharge guidance. I think you were also at that meeting with Miss Pritchard, and there was discussions in that meeting around consideration to be given about testing practices at the discharge point to support safe care home discharges. Did PHE take that issue further, that consideration of testing before discharge?
So I don't recall that meeting. I don't know if I was at that meeting. I definitely don't have any recollection more than 5 years later on anything that you're mentioning now.
OK. So do I take it from that answer that you don't recall PHE being tasked to consider anything regarding testing from hospital discharge into care homes?
No.
Were you involved in any conversations at PHE about whether discharging policy could be deferred pending further capacity building around testing?
No.
Ms Pritchard went on to say in her statement that by the 1st of April, NHS England understood that a large number of hospitals may already have moved to be testing symptomatic and some asymptomatic patients before discharging them into a care home. Was PHE made aware of that?
So not that which hospitals were, but I think I included in our statement, and we have records of numerous people saying, if you can test and you have capacity, then please do. This is not a decision of no testing required, but it's a balance of prioritisation of your testing needs. So I don't know what individual hospitals were deciding at that point.
Okay. So her evidence is that they thought some that may have been, but you say that PHE weren't aware that.
So we wouldn't have known which hospitals.
Okay. All right. My question is then, if there was some testing going on, does that indicate a recognition by clinicians within the hospital at that stage that there was an on-the-ground appreciation that it was inappropriate to discharge patients to care homes without that testing where there was capacity to do so?
So I think what we were trying to do is understand where we could test more. So if, for example, in hospitals at that time, individuals may have been tested because they were developing symptoms in hospital. They may have been developed because they were a contact of a case in hospital. And they may have been tested because that if there was capacity, it would be good to know before they were discharged. But this was a balance of ensuring that the individual was at the right place for their residents, for their ongoing care, and ensuring that the testing capacity was prioritised to the individuals who needed it for their own care.
So whilst recognising that testing doesn't remove all risks associated with, for example, asymptomatic transition, do you agree that the requirement to test before discharging into care homes should have been introduced before April 2020, 15th of April?
So first of all, when we introduced it on April 15th, 2020, it was really important that it was introduced not just as a test and discharge, it was a test, discharge and continue in isolation. Partly because we really did not know at that point in time what a negative test meant. So, for example, a positive test we were very clear on, but we did not know how long a person would be negative before they became positive. And so there was a lot of anxieties about the false reassurance of a negative test at that time, and it continued for some time. So I think from my point of view, this was a balance on what capacity there is in testing, where do we prioritise that capacity, which we were prioritising to test in care homes, in hospitals where they had capacity to test, We had a list of criteria that we had sent to them in early March about how they would prioritise testing in hospital, which included being in contact of a case, etc. So that would have been part of the considerations, I think, rather than just purely discharge testing into care homes. It would have been one of the many considerations hospitals would have done in prioritising their testing.
Moving then to the April admissions guidance, you've been asked some questions about that 2nd of April, what I think you've termed it the consensus guidance. And Ms Carey, King's Counsel, has touched on some of the underlying emails that were exchanged around the 24th of March on the topic. One of those emails referenced it from the Deputy SRO for PHE, Professor Johnson, who noted that, quote, mustn't be pushed into agreeing the consensus guidance. He also said that he'd only found out on the 24th of March that this guidance was being written at all. So there seemed to be some surprise expressed that this additional guidance was being prepared. The internal PHE emails record that in a meeting, there's a view expressed by Mr Wynne, the NHSE Director for Ageing, and his team, that, quote, the overall balance should be about reducing the risk of care homes not taking back existing residents or new transfers. And it was noted in the email that their words were that, quote, it should be made clear to care homes that they should only refuse patients in the most extreme cases. An email chain the following day shows that you reviewed the NHSE changes and that ultimately they were agreed by the PHE. So do you agree that the NHSE insistence that social care should only refuse to admit transfers in, quote, extreme cases was incorrect, having regard to ASC governance arrangements and their providers' duties to safeguard residents within those care homes and their staff?
So I think that at the time, there were two very diametrically opposed components that we were trying to bring together in that consensus guidance. I think it's really important that care home providers are able to do an adequate risk assessment for their individuals who they're admitting, and that equally the NHS needs to understand the views of the wider sector whilst they're developing guidance as well. I think it's really important that we remember the moment where the hospitals were worried that they were not going to have sufficient beds to care for individuals. And we had seen that take place in other countries in Europe and in North America. So it was a real live risk. However, I think my view is that coming out of this pandemic and where we are now, we should really look at what we can do to balance the needs on both sides. And that needs to bring together the care sector more eloquently into the centre of this conversation rather than aside.
I appreciate that forward-looking sort of recommendation, but on the 24th of March, between then and the 2nd of April, you were very clear to say you're sort of trying to find a balance, but was the reality that PHE was pushed into adopting this wording with fewer safeguards for the adult social care sector?
So I think this is, as I've said, a consensus. So there's not being pushed one way or another. PHE, I think at the time, highlighted when somebody with COVID or known to have COVID was coming back, what that needed to be done. It highlighted what needed to be done for individuals who were asymptomatic, who developed symptoms. And it was trying to draw that balance between ensuring that there was space in hospitals and safety in care homes and a recognition in care homes in what they could do. So I think this is a balance on both sides, and as always, being brought together by the Department of Health to look across the different systems and bring the whole system together.
My third and final topic is returning to the issue of data, please, and in particular the PHE linkage report, because you say in your statement that the evidence suggests that hospital discharge was not the dominant cause of outbreaks and that outbreak levels were broadly consistent with infection rates in the community. There's no caveats in your statement, and you mentioned in answer to Ms Carey's questions about whether there are any caveats in the PHE linkage report from July 2021 itself, and that can of course be checked. You accepted in response to Ms Carey's questions that the PHE data linkage report was based on the Pillar 1, in part on the Pillar 1 data that PHE had been using in 2020, if I've understood that correctly.
The data in the report's Pillar 1 and Pillar 2.
Yes, but the Pillar 1 data is limited up until May 2020.
That's the only data that was available till the start of April. But from April, it was Pillar 1 and Pillar 2.
And the important caveat to that is that the Pillar 1 data had limited testing capacity available to it.
Well, Pillar 2 had none before that started in April. So Pillar 1 was the only capacity that was available to the country until April.
Understood. So, and you've accepted as well this morning that it's likely that 1.6% is likely to be an underestimate, and the limitations, the caveats are around the testing capacity at that point, that data point.
Correct.
Thank you. So there are limitations, there are caveats that can be applied to it. Mr. Donaldson, who is an official at the heart of the COVID-19 response and an official responsible for creating the Vivaldi study, suggested that therefore extreme caution should be utilised when trying to understand the PHE linkage report. Would you agree with that?
So I think the initial report was developed, and the subsequent fuller reports that are in peer-reviewed publications were also developed. And actually, they look at the same data and as it was developed over time, over a prolonged period of time. So even in the winter of 2020-21 and the subsequent period of time, the amount of infections that were able to be diagnosed coming into care homes was extremely low, despite whole care home testing being available. So, of course, we should always be cautious on data. We're cautious on all aspects of data, and particularly in the data from March, April, where there were limitations in testing. However, the data, as I've said previously, lays out the definitions that's utilised, lays out how the data was analysed, and applied that consistently over a prolonged period of time to try and give the best assessments they could from the routine data. Always should have cautions in the data. You always need to understand how the data is developed and delivered, but it's clearly described in the reports and in the final peer-reviewed publication.
All right, thank you. Mr. Donaldson goes on in his witness statement to tell the chair that he, quote, repeatedly witnessed how relevant members of PHE and SAGE, who had overseen and failed to warn against or properly mitigate the tragic initial errors, consistently used inadequate methods and extremely faulty data, which played down the seriousness of the problem in care homes. Would you agree?
So I'd like to see Mr. Donaldson's evidence. I don't recognise that.
And in his concluding remarks, and it may be helpful to a lengthier paragraph for this to be put on the screen, please. It's INQ 000598578 at page 35. You're likely to be able to read quicker than I can speak.
It's not on the screen yet, so.
It's at paragraph 111 of Mr. Donaldson's statement. Thank you very much. I'll just read it for the record. He says, in summary, we had to create Vivaldi because PHE and DHSC ASC policy teams had failed to do so. We had to use outsiders because they wouldn't and perhaps couldn't do it themselves. Parts of PHE and DHSC ASC effectively tried to stop Vivaldi happening, then tried to stop it reporting, then tried to avoid acting on the results, then tried to stop the creation and use of our data dashboard. Having tried to stop our initial report, PHE first tried to ignore it, then tried to steal it and present it as their own, then tried to reinterpret it as justifying its own previous policy failings. DHSC refused to share data, even when ordered to by ministers, and regularly proposed not telling ministers important information. I believe that this all suggests a pattern of dysfunction that helps to explain why things were so bad with care home policy making at the start of the pandemic and gives a broader clue as to the systemic problems COVID revealed. What's your response to this statement?
So clearly, when we talk about PHE and DHSC, it talks about large umbrella organisations. The organisations were increasing in size very, very rapidly. I was at the centre of Vivaldi creation, as I've said in my previous statements for Module 7. And also I've seen Laura's statement for Module 6, which I had not seen until it was released. So from my point of view, clearly as a member of PHE staff and as the incident director, I was involved in its construction. So some of it just doesn't recognise to me. I discussed its development and its production with the adult social care policy team, as I would, because I wouldn't do these things by myself. And clearly, I already highlighted why we went outside, resourcing numbers of technical experts and the ability of studies like this to have independence. I did everything I could to facilitate it personally, and I know that lots of other people did too, in order to get it through ethics committee, write protocols, ensure that we get the data across. So, what I would say is the organisations were very big and they increased very, very rapidly in this time. And I have no doubt there was friction. And I have no doubt that there were individuals who were worried about components of it. Is that how it felt to me as the incident director? No. People were by and large trying their best. Sometimes you had to get things done a bit faster. Sometimes you had to mobilise resource from here to there. But that was part of acting in an emergency and a response. In terms of the results, I thought the results were really important. They were presented at the data group which John Hatwell, one of the officials in the department leading Pillar 4, brought together, where I was presenting the siren results at the same time. So we were presenting the results in real time, often off the top of our heads in doing it. We were relying on lots of people to share those data across organisations, and we were putting them into SAGE and to other components as fast as possible. Clearly, sometimes it was not fast enough, right? I completely sit back and go, how could we have done things faster? But people were really working very hard. I never saw people steal data, though I'm sure that people were presenting slides that other people had utilised for another presentation over here, or there were 2 meetings going on and different people did it. So for me, this just doesn't recognise and feel how I worked throughout the pandemic, and particularly in those early months of Vivaldi. We continue to support Vivaldi as NHS Test and Trace, and we continue to support Vivaldi now as UK HSA. I think it's an important study. It was the first of its kind in the UK and globally. And from me, everyone was there to support it. And I just don't recognise this.
Thank you. Those are my questions. Thank you, my lady.